Good afternoon, I'm Geneviève Tourigny-Ruel. I'm a staff emergency physician at Saint-Justine. Today, I'm very happy to discuss with you the management of patients with special needs and behavioral aggression, together with my colleague, Caitlin Gattuso, who is a certified child life specialist. First of all, we have no conflicts of interest to declare. The learning objective for this afternoon will be to discuss basically an approach to assess the children with special needs presenting to the ED with behavioral aggression, as long as non-pharmacological and pharmacological strategies to manage them. So first, when I talk about children with special needs, I mainly talk about children with autism spectrum disorder, which I will refer to ASD in the next few slides. Also to children with developmental delay, sometimes not yet diagnosed. Basically, all the kids that are developmental delay with being nonverbal. They are not very sensitive to pain, but they're very sensitive to discomfort. Discomfort from anything in the mouth, so teething, tooth decay, dental abscess, anything in their abdomen, constipation, anything in their skin, like pruritus from eczema, or something iatrogenic, like an NG tube, an IV catheter, a urine catheter, a cast, some medication-related problems like itching. And also, they're very sensitive to changes in their routine and their environment. So as you can imagine, the emergency room is an aggressive environment for them. So our job is to optimize our emergency room, but also to minimize the time that they will spend in it. So now, talking about how to approach them, at Saint-Justine, we developed some really nice clinical guidelines. You can access to them on our website, so www.Urgencehsj for HôpitalSaint-Justine.ca, and you'll see them listed. So the protocol that interests us today is the one talking about agitation. So first, on the history, you want to look what's causing the agitation of the kid coming in the emergency. As we discussed before, is it a source of discomfort or pain? Could it be a source of infection, like a sore throat or something like that? Most of the time, it's the exacerbation of their baseline pathology, like a behavioral disorder. And you want to make sure it's not something else, but it's very rare, but something like a metabolic disorder, intoxication, encephalopathy, or a psychiatric disorder. You want to do a real good physical exam, really complete from head to toe, including some vital signs. And it's a challenge because even from triage, most of the time the nurses won't take the vital signs. So really, you want to do a complete physical exam. You want to pay specific attention to the ENT and mouth exam, as we said, looking at all the teeth and the tympanic membrane. Abdominal, a good abdominal physical exam too, looking for constipation, good skin exam, and a good MSK exam looking for fracture, dislocation, or even a pulled elbow in a younger child. How are you going to do that? That's what you're going to ask me, and we'll come back to this. Same thing for the investigations. So most of the time, we don't have to do anything because it's really an exacerbation of their underlying disease. But if you need, how are you going to do it? Okay? So now, let's look at that. To present all our strategies, I'm going to present to you 3 cases, and we'll come back to the cases after we have presented to you the non-pharmacological and pharmacological strategies. So case 1, it's a 14-year-old girl. She's known for trisomy 21. She's nonverbal. She's coming in with agitation. She has no really past medical history, but she came a month ago for the same reason, so being agitated, and she was diagnosed with constipation, sent home on laxity. Today, you're unable to do the physical exam because she's non-cooperative. So it's very difficult, but she looks well. Your colleague that saw her sent her to the abdominal x-ray and prescribed urine analysis. You're the one reassessing her about an hour later after the abdominal x-ray is done. So she comes in, she looks in pain, and her mom tells you that she's unable to urinate. So that's odd. So you ask her to lay down on the table, and then, wow, you figure out she has some defense on the abdominal exam. So in your head, it's a total shift in your diagnosis. So you will want to do an ultrasound, you will want to put an IV and do some blood work. So how are you going to do that? So So for any other kid, you would send the kid maybe back to the waiting room or even directly to a procedure room to do the IV, the blood work, and then the ultrasound. But that's multiple transport within the emergency room. So it will lead to more agitation. So that's what you want to avoid. So we'll think about a better plan. Case number 2 is a 3-year-old boy, autistic child, coming with a shin laceration. He has no past medical history, but he's super agitated from that cut, from the emergency room, from everything. So there's no way you could repair that like this. So you're thinking about repairing under ketamine, but then you're unable to put an IV. Oh, so what's your plan B? And finally, the third case is a classic case, a 12-year-old boy with a syndrome NYD, also known to be autistic, coming in very agitated. In fact, it's a child who you know from before because he's returning to the AD every holiday. So he usually goes to school. He's pretty okay. But each time he has few days at home, he gets very agitated and mom doesn't know what to do and she brings the child to the emergency. So your physical exam is very limited because it's an 18-kilo boy, so big boy. Very energetic, very agitated. So what are you going to do with this child? So now I'm going to let Caitlin talk to you about the non-pharmacological strategies.
So certified child life specialists are often involved in facilitating the use of non-pharmacological strategies to reduce pain and distress for children in a healthcare environment. Many of these strategies that we will review in the next few slides have been effective in promoting coping for children and adolescents with special needs during their healthcare encounters. So simply put, the most important strategy is to learn from parents. Parents are the expert of their child. They know their child best. So to follow their recommendations to meet the unique needs of their children would be the most appropriate. Especially in a high-stress environment such as the emergency, parents have perhaps known strategies for changing expectations, routines, and introducing new behaviors. So their recommendations should be followed. Along those lines, parent engagement can be facilitated through the use of individualized care plans, which are family-centered treatment plans to promote positive healthcare experiences. These are also known as adaptive care plans or coping plans, which collect information about a patient's sensory and emotional triggers, reactive behaviors, their communication style, including the way they communicate pain, coping strategies, and de-escalation techniques for known stressors. So in the ED, this can be a one-page checklist that is given out at registration and flagged with an alert in the patient's chart. And studies have shown the benefit of these care plans and how it has been positively evaluated by both parents and healthcare professionals. So for parents, there's no longer the obligation to repeatedly disclose their child's diagnosis and needs every time. And for healthcare professionals, with even just a few quick tips, they're able to have a quick idea or a quick glance at how they can adapt their interventions to better accommodate their patients. So overall, it's a great tool to honor parents' expertise, promote family-centered care, and determine the best methods to optimize care and make these children feel safe and comfortable even prior to their healthcare encounters. So for communication, challenging behaviors such as behavioral aggression may be the child's way of communicating their frustration, their inability to express themselves or to be understood, such as their difficulty perhaps communicating pain or discomfort. And so depending on the child's communication style and their level of comprehension, there are various communication aids that can be utilized to facilitate communication, including visual schedules, communication boards, pain scales, social stories, role-playing, technology, and other applications. So other communication tips involve pausing after a question, advising what you will do beforehand, offering choices, breaking down the directions into steps and structuring activities, and offering frequent praise and positive reinforcement as each step is completed. And so for our case number 1, pictorial support can be especially effective for a patient that is nonverbal, but can be utilized in any of our cases to facilitate communication. And I've included some examples here for a communication board, a pain scale, and visual timers are a great way to structure activities. So, for example, if a parent agrees that in such a case like case number 1, that it would encourage their child to stay still for a given procedure, that might encourage and motivate the child to comply as well. So all of these actions improve the child's way to communicate, make decisions, and have some degree of control, which can decrease anxiety. Another way to reduce behavioral aggression and promote better cooperation of these children is preparation. So it's crucial to prepare children for transitions and medical procedures in order to reduce their stress. And it's important that children are prepared in a way that they can understand. So social stories break down procedures using short descriptive sentences, and they also facilitate social understanding, which may lead to improvement in behaviors. Visual supports are a little less elaborate than social stories, but still provide a visual sequence of events. Now then, or first then pictures are prompts on a visual schedule that can cue for transitions, alerting the child of any change such as switching a room, taking vitals, or starting a procedure, which could be triggering. And these are all examples from Autism Speaks to prepare a child for a blood test, but can be adapted for any given procedure. Medical play is another great way to prepare children. It allows them to familiarize with the medical materials. It promotes a better understanding of the procedure, and it encourages children to express themselves. So, time permitting, for case 1 and case 2, you can prepare the child for whether it be the ultrasound, the IV, or the blood test, desensitizing them to these medical materials and promoting resilience. There are also technology and other technological online resources, applications like Santé BD, which is a type of comic book social story that is available in various languages for many different medical interventions. And what I really like about it is that you can customize the patient based on their gender or specific needs, which allows for a more accurate visualization and relatability. And it will promote overall a better understanding. And so finally, although it's not a one-size-fits-all, if you have pre-prepared grab-and-go kits for coping kits that include communication aids, preparation books, and distraction items, it can be very useful in a hectic environment such as the emergency. And so overall, knowing what to expect can reduce a child's anxiety and thus help the child collaborate throughout their healthcare experience. Distraction is a powerful tool that can be used before a procedure to normalize the environment and establish a therapeutic relationship, during a procedure to refocus a child's attention on less threatening stimuli and promote a sense of control, and even after a procedure to allow for recuperation, promote coping, and really have a long-term lasting impact in facilitating future interventions. So for distraction to be effective, consider the patient's interests, utilize the items that they brought with them, whether it be a comfort item or a favorite toy, provide choices of various different activities, and we've included some examples here. So depending on a child's development, you can provide videos, music, interactive games on a phone or a tablet, games that require little or no movement, toys that are visually stimulating, tactile toys or objects, new toys that are visually interesting, make some noise, or are tactile, and my personal favorite right now are rain sticks and poppets. Relaxation techniques can also be distracting, and I've included Buzzy as well, which is a new resource that we've recently deployed in our emergency department. It's been recently approved by Healthcare Canada to reduce pain during needle procedures, but also provides distraction and sensory stimulation. And at the bottom, there's also a link that I've included for the Saint-Justin's distraction kit and guidelines. Often it is assumed that children with special needs, especially those displaying challenging behaviors, will not be able to collaborate nor understand and thus need to be restrained. When a child is already agitated, restraining them will agitate them more. During procedures, comfort positions can be encouraged to allow the child to feel safe, comfortable, in a secure position, so they can be seated with a caregiver, whether that be sitting on a parent, hugging a parent, or just being in really close proximity to their parent. And this will minimize the stresses for both the child and the parent, and I would even go as far as saying for the healthcare professional, and reduces the time of the procedure as the child is more likely to comply with a comfort position. And comfort positioning could be especially effective for our 3-year-old with the chin laceration, if that's possible. A noisy hospital environment, such as the ED, with long waits, crowded waiting areas, can be provoking to children with special needs. So whenever possible, to mitigate sensory triggers, close the doors. You can use do not disturb signs, you can dim the lights, cluster your interventions and advocate for the least number of interruptions, provide a quiet waiting room section and or private patient rooms, remove unnecessary equipment or hide it from view. And during procedures such as the ones in case 1 and 2, if possible, limit staff so as not to overwhelm the child, enter the room one at a time, and only one voice should be heard to reduce the noise. Something we're hoping to integrate in our ED are sensory-friendly spaces. Sensory rooms or snoozlin rooms are becoming more and more popular in healthcare settings such as the ED. So these therapeutic spaces provide calm, they reduce agitation and pain, and through the use of gentle lights, soothing sounds, and really interesting textures and visuals to explore. So for all our case examples today, a sensory-friendly space would be beneficial. If a patient is aggressive, you can provide a room that has floor padding, wall padding, a soothing projection, soothing sounds that could provide security and relaxation. If a sensory room is not possible, you can purchase online sensory carts, or you can create your own using various auditory, tactile, and visual items. So I will hand it over back to Geneviève with the pharmacological strategies.
So if none of the previous strategies have worked, or also to help them work, you can use some medication. So first, if the patient is already receiving a psychiatric medication, either benzo or antipsychotic, favor it. So if it's time to give the next dose, just give it. If not, you can administer a quarter to half of the total daily dose. Benzo we tend to avoid because patients with ASD are more at risk of having paradoxical reactions that you want to avoid for sure. So our favorite medication, our first-line PO medication, is olanzapine. So the ODT form, because it's orally disintegrative pill, so it's very easy to give under the tongue. It's even better, and it's got to dissolve very, very quickly. So you can see the doses here. It works with the weight. So the onset of action is about 20 to 30 minutes. So in the meantime, you might want to use the other strategies that were mentioned by Caitlin. The EKG, so a 12-lead EKG is needed only if the patient is intoxicated and known for a long QT syndrome or already on QTC prolonging drugs. That being said, if the patient is already on an antipsychotic, you don't really need to do an EKG if you're only going to use 1 or 2 PO doses. Then the second line would be IM or IN medication, so you can give the same molecule, so olanzapine intramuscular. The olanzapine is I forgot to mention, but it's a second dose, second generation antipsychotic, so known for less side effects. Then after the olanzapine IM, you could use also haloperidol, which is known for a long time, but the child is more at risk of having some extrapyramidal symptoms, so you might want to use some Benadryl when you give the haloperidol. And then your third choice would be lorazepam. And you can give also midazolam. Midazolam could be given either intramuscularly or intranasally, which is a good medication too. And intranasally, it acts a little bit quicker, so 10 to 20 minutes. You want to make sure you wait for the clinical effect, because when a child is being very aggressive, you're giving a medication, then 5 minutes later, everybody's bugging you because the child is still aggressive. So you really want to wait for the 20 to 30 minutes before the medication is having its clinical efficacy. You will give 2 doses of the same medication, and then if there's really no response, you should change drug to help you. Don't forget to also consider analgesia if the patient is either uncomfortable or in pain. You can use also topical analgesia, like some Maxilin before you do the blood test or the IV insertion, or some LET if you're going to do the laceration repair. You can consider nitrous oxide, which is a very good thing to complete your physical exam or your investigation as well. And in the end, if you need to do a procedural sedation, you should avoid ketamine with ASD kit, but favor intranasal fentanyl and nitrous oxide or propofol. If you do use medication, make sure you're going to monitor the vital signs and the neurosigns every 15 minutes until return to baseline. We know with olanzapine or even lorazepam, there can be some respiratory depression, so you really want to look at those kids and monitor them. Minimum would be vital signs and O2 sats every 4 hours. Also, if you give some analgesia, do a pain scale every time you go in and take some vital signs. Physical restraint would really be a last resort. So, I mean, if nothing else is working and you're worried about safety, you need to obtain a consent form, so the parents need to be consulted, and if it's mutually agreed upon, then you can go with the physical restraint. Make sure you still monitor the child, so vital signs and neurosigns every 30 minutes while the physical restraints are put in. Then, back to our case examples. So, case number 1 is our 14-year-old girl, T21, coming with some agitation, abdominal pain. When we reassess, we figure out she has some defense on the physical exam. So it's a really nice case. So we were able, with the child life specialist, to have the child come down, and then we discussed with radiology to do the ultrasound in the crash room. So from the examination room, we moved the patient only to the crash room. We put some topical Maxilin, we gave some intranasal fentanyl, and then when the lights turned down and mom only talking to the patient, we were able to do the abdominal ultrasound, which showed an hematoculpus, likely secondary to imperforated hymen. So very interesting cases. And then after the abdominal ultrasound was done, we did the blood work, put the IV, and then moved the child to the observation room. So that's really nice. It's when everybody is playing in a team, is acting in a team. So that was a really good case. Then case number 2, I'll let Caitlin explain to you.
So for case number 2, this is actually an inspired case where I did a lot of work with this patient. Initially, they were throwing things. And so I discussed with the parent about previous medical experiences, what works, what doesn't work, any known stressors. I offered therapeutic play, normalization activities to help calm him, establish some trust. We applied the Maxilin magic cream. Buzzy was introduced and as well as medical play to prepare him for the IV. And 2 attempts were made for the IV, although it didn't work, the patient became too agitated, so we were unable to put the IV and had to think of a plan B. And so plan B was to bundle the care. Nitrous oxide was proposed for IV start prior to ketamine, and the mother agreed with this plan. The child was prepared for nitrous with the mask to allow for some familiarization and exploring. First then pictures were used to break down the sequence of events and cue transitions, and only staff required for a specific intervention were present. The remaining staff stayed at a distance since too many people near the patient was a trigger. And what ended up happening is the patient collaborated extremely well with nitrous that ketamine was not even required to do the laceration repair. And lastly, for case number 3.
So back to our 12-year-old boy who was very agitated. So turned out, so child life specialist came. We did all the previous mentioned strategies, and then with the mother, we decided to give some risperidone because the child was already on risperidone, and it was close to dinner time. So he received his usual risperidone dose. 30 minutes later, still very agitated, so was given a quarter of his total daily dose. 30 minutes later, still agitated, so then we went for a 5 milligram of olanzapine ODT form, and then the child was really calm, and we were able to introduce the social worker to try to find a plan, for next time the kid would come in. Every time he gets agitated, the mom cannot really return to the emergency. She should have other strategies, right? So that's our 3 cases. So our conclusion is that, unfortunately, there's no magic formula, but there's a lot of tools, okay? So pharmacological and non-pharmacological strategies can help reduce challenging behaviors and promote positive healthcare experiences, both for children with special needs, their parents, but also us, the healthcare professionals, okay? For more resources, you can go back to our clinical guidelines on the website at Saint-Justine, but also To Do, which is a project at Saint-Justine. Thank you. Does anybody have a question? And this is our references.